This is the Health and Politics podcast. Prevention is the new cure.
And that's with former ministers Steve Brine and myself, James Bethell.
Hello, James. You're looking very smart and you're in a very posh location there. I can see wood panelling.
Yes, there is. I know, really old school. I'm in the City of London in wood panelling. I'm at the Mercer Advisory Council. We're looking at the statistics around health and wealth. And it's a really important subject. I'm really pleased to be here, partly because the NHS and the ONS have backed off calculating outcomes. They've dumped a load of figures like the health index that used to be done. And the materials published on this aren't what they should be. Now, I should give a shout out. There are some excellent people doing excellent work. Adam Memon, Natasha, there are Chris Thomas, all friends of the podcast. They are still absolute evangelists, Axel Heitmuller in number 10. But there is more that needs to be done by the private sector. So that's what I'm doing here.
Oh, fantastic. Yeah. Well, do you know, I saw a friend of ours last night, Sir John Curtis.
Ah, yes.
I know you've met John many times, and I was saying to him, you know, it's a bit like a vicar for you. You're coming into Christmas, aren't you? Because this is literally his time. And he said, oh, my wife's a vicar, so I know all about that. But of course, he, those who don't know, University of Strathclyde, very, very famous face, always on the telly and on the radio and online at this time of year, because he is the election guru, literally the election guru. And he was doing an event for a client of mine called GK Strategy, with lovely people, at the Conrad Hotel in Westminster, just sort of talking about why the landscape's changed and, you know, giving a look ahead, obviously, to the elections that are coming up on the 7th of May. And look, we do health and politics on this show, so I was just sort of struck by this quote. He said, for Labour and the Conservatives, these elections will pose the question, will it be bad? Will it be very bad, or will it be existential? That was the summary of his presentation. So, yeah, really, really interesting. And what a guy.
It's like going to see your finance director, and you've had all these plans about your business, and you've done this or that, and then he reminds you about the income and costs and the profit, and suddenly reality hits you in the face. That's how politicians feel. When they've spent months or years larking around, and then suddenly he spells out what it'll all mean in terms of the number of seats in the next election. It can be pretty grim.
I hope I planted a seed with him, actually, because I was asking him beforehand when we were chatting about the issues, and the issue tracker, because we've discussed before, the issue tracker has shown health just slipping down, the issue tracker, the YouGov monthly issue tracker, health in terms of what's important to people, going down. And he was like, oh, really? I need to have a look at that. He was I think he was circumspect as to whether that is real. But it is, sitting behind immigration, cost of living, defence of the realm, on the tracker. So hopefully, if you hear him talking about health and where it sits on the public priorities, maybe that's because of the conversation we had over a Diet Coke. The other thing, James, I just want to shout out to another podcast, Political Currency, which is done by our old friends George Osborne and Ed Balls, who very kindly gave a plug to this podcast the other day, and very, very kind of them to do that. And they were having a conversation about Wes Streeting and whether he is going to be seen as, or is seen as, a successful health secretary. And Ed's thesis, if you like, was that it's all about delivery for Wes. And of course, the clue is in the name of that podcast, which is Political Currency, which is, if Wes Streeting is seen as a successful health secretary, it will be because he's delivered on 18 weeks. It's because he's delivered on the ED targets, the cancer targets, and those things. But my experience of this, I think it was George Osborne who actually said this to me when I became a health minister, is all the good decisions you take, they won't come to fruition until long after you've left office. And boy, was that true.
Steve, I have a totally different read on that interview. I thought that they got it badly wrong. Ed Balls said if a Secretary of State for Health should be judged a success if he keeps health out of the headlines, and basically. And that's not true. It should be that it's because they've improved the health of the nation and delivered for the country in terms of economics and personal development. And they should be judged on that because voters aren't stupid. We shouldn't deride them. They can assess successful outcomes or not. And that kind of nihilism, that kind of political kind of lack of creativity and imagination, that really all you've got to do is keep health out of the headlines and you've done a good job, is kind of the root cause why we can't have programmatic reform, strategic thinking, and outcome-based health targets. I had a glimpse into the soul of the political strategy that has led to a lot of problems in our system. And I found it really revealing and frankly sad to hear
No,
it
it
in
was.
such stark terms.
I agree. It was interesting, and it was very Blairite, Brownite era, wasn't
Yeah,
it?
it really was. But we're living with that. That hasn't changed, really.
I suppose that shouldn't be any great surprise.
And it links to what you were saying about John Curtis. West Streeting has done well to keep health broadly off the headlines, broadly. And that has meant that the saliency has gone down. But has that really meant that it's in the next election, the voters are going to think that this government's done a good job? I don't think so. I think
no, because it's all about lived experience, isn't it?
Yeah, exactly.
Ultimately, I was just finally on this. I was at a dinner the other night with Patrick Maguire from the Times, who's very much thought of as the Labour whisperer, and he was asked by a very senior charity leader, and I won't say which, 'cause I'm not sure. I don't think it's fair. He was asked about West Streeting, and look, the question was, we're beginning to wonder, is it about health? Or is it all about the politics? Because, of course, when you talk about West Streeting, yes, you talk about health, but you also talk about his ambitions for the top job and, him being a great communicator and the politics. And Patrick's answer was, well, look, you've got a health secretary who used to lead the NUS, who is Labour to his core. It wouldn't be a great surprise if he was very, very political in what he's doing. But I just thought it was interesting that somebody who leads a very, very big charity in the health space was basically asking that question as to, is it about health or is it actually just about the politics and a stepping stone to something else? And I think that question mark does hang over where's his record as Secretary of State at the moment.
It does. And I think that there is a third option. Listen, if you speak to Wes or see him speaking, he clearly understands intellectually the issues, and is, I think, a fellow traveller with this podcast in terms of what prevention should do. Now, it's a skill of politician to make everyone feel like that, but genuinely, I think he gets it. But he hasn't moved the needle at all, and I don't see that happening anytime soon. The third chance is that within the team of Wes, Keir, and Rachel, who are the kind of like key personalities of the current project, has he been able to persuade Rachel and Keir that large-scale reform, investment and change and political creativity and risk-taking is a desirable priority? No, he hasn't. And in that he has failed, and therefore is stuck in a very narrow kind of channel of just basically the same old playbook, and with a very, very tight budget and trying to avoid strikes. And it does remind me a little bit of our dear friend Jeremy Hunt, who kind of found himself in the same sort of channel with George and Dave. He was Secretary of State for 7 years. I mean, he understood the issues and would have liked to have done more, but found that his agreement with the Treasury and Downing Street was quite tight, and therefore his freedom for operation was quite small and wasn't the great reformer that maybe he would have liked to have been. So there's a little bit of a parallel there, I think.
Yeah, and he's very reflective these days. We've had him on the podcast before when he was Chancellor. We had him on, but let's get him on actually now, because with that event that you and I did in Parliament together with Claire Gerarda a few months ago, Jeremy also did that event. I think it was very reflective looking back, because time allows you to do that, doesn't it? Let's get him on and talk about his time as Health Secretary. Just before we move on, James, we always saying, aren't we, on the show, send us a voice note to our WhatsApp number, and I'll give that out in a minute. Anyway, a doctor from the West Midlands, a GP from the West Midlands, has sent us this voice note. Have a listen.
Hi, both. I really enjoy the podcast and have been a listener since we've had him. It's pushed me to think outside my usual perspective, but I wanted to respond to a point Lord Bethell made, which ended with, there is no way that our tiny population of 23,000 GPs can give everything that all those people need in order to manage their health. And we've just got to get past this point somehow. The problem is the core function of general practice has always been the management and holding of risk. A GP's role is not simply to process symptoms, it is to recognize when a common presentation may conceal a serious condition. That needle in a haystack work is not a flaw in the system, it is the system. So shifting away from this model means accepting that some patients will be missed. That trade-off may make sense at a population level, but it has real consequences for individuals. A delayed cancer diagnosis, a missed neurological event, it's not an abstract outcome. And the inverse also applies. Without experienced clinical judgment, there is a risk of over-investigation and unnecessary advice and guidance requests, adding to the burdens without improving care. If general practice is to function effectively, it needs to be expanded, not diluted. Without that, we risk building a system that isn't efficient on paper, but one that is less safe, less personal, and ultimately less effective. From Dr. Anj Patel, NHS GP in Warsaw.
Okay, so taking us to task there a bit, James, what did you think when you heard that?
Hey, listen, it's so great to have GPs engaged.
Yeah.
But there's a really big contradiction here. The point I made that 23,000 GPs can't look after the health of the nation on their own is clearly correct. But his point that they are risk managers rather than actually delivering every piece of treatment is also correct. Where I think the friction is, I mean, there's a lot in that, but if I was to point out one thing, it's the question of delegation. Are GPs genuinely operating at the top of their license? Are they genuinely working as managers of risk and engaged in the population health of the people on their register? Or are they slightly stuck in a sort of cycle of 7-minute appointments, doing quite day-to-day stuff and fighting off anyone else who wants to get involved in that process? I think they don't delegate enough. I think there's a skills gap in terms of the management of large population health challenges. I think that they should be embracing technology and also non-GMC trained people to do some of the work, particularly on chronic disease, where frankly GPs are not necessarily the best people and don't have the capacity for the extensive time required to manage those conditions. And there's just a lack of realism about what the role of a GP should be in the modern British health system. So this is a really important debate. I don't want in any way to come across as anti-GP. I'm just pro-GPs doing more managerial oversight type stuff and less trying to be the old-fashioned country doctor.
Yeah, I would agree. I was in Salcombe last weekend with the family, which is, and they have it had a Boots pharmacy there for years. And then it was called Jahoots, and now it's called Pharmaderma, and it's a private pharmacy. Anyway, I was talking to them. They do NHS prescriptions, all sorts of minor stuff, and I was chatting to them because they were having their big opening on Saturday, and I was asking, we were chatting about what I used to do, and we were talking about primary care networks, and they were saying that yes, primary care networks, great idea. The idea of bringing that wider primary care family, including pharmacists, who of course are medicine specialists, great idea. But the reality is that they still face resistance, and resistance, I have to say, from general practice to that wider primary care family, who are also on the one hand saying they can't cope, on the other hand holding a little bit at arm's length some of the wider primary care family. So that would be the challenge that I made as primary care minister to GPs and would to our correspondent. But that said, we are incredibly grateful that you got in touch, and you can do so too. 0333 404 6507 is our WhatsApp number. Anyway, let's just quickly go through what's coming up this week, James. Really, really busy in a good way show this week with lots to get through. So we're going to start with the promised school dinners revolution. Does the evidence suggest it's already backfiring? ?
Then we're going to touch on a really important event that took place earlier this week at the Academy of Medical Sciences called Prevention and Early Detection. So absolutely up our street, and we're very grateful for the invitation. And we're going to hear from some of those involved because Prevention is the New Cure was there.
Indeed. And after that, we've got a live guest on the show from Prostate Cancer Research as we look ahead to a big moment in that space coming up next month. We'll try to consider where the innovation is in early stage prostate disease.
And we finished by considering whether Steve's park run is just held at the wrong time of day, as recent evidence would seem to suggest, for his internal body clock, that is. A new study suggests that maybe that's right. Steve, we're looking forward to your personal testimony on that.
Indeed. So thanks for listening to our show. It's called Prevention is the New Cure. We do health and politics. We're just two former ministers, hopefully offering some insight into how decisions are made at the heart of government. As you listen, we'd be delighted if you'd hit subscribe. Then you get our brand new episodes, which come out on lunchtime every single Thursday. So ministers this week, James, one of the big stories in politics politics and health this week. Ministers announced the biggest overhaul of school food standards in over a decade. They're going to ban deep-fried foods like nuggets and fish and chips, but not on a Friday, restricting sugary desserts and requiring healthier menus from this September. Obviously, school food potentially big universal prevention tool, but only if children actually eat it, of course, and schools can afford to do it properly. So this was a big announcement this week, and the Education Secretary was all over it on the news. Did you catch the story?
I absolutely did. This is so important, Steve. I mean, I am totally passionate about it. There are some public policy interventions that are catalytic on many levels. And getting the school food system right is just absolutely important. In instilling good education to kids, ensuring that they get some respite from the junk food that they might be eating elsewhere, to make sure that they pay attention during school, to support those who struggle with getting enough nutrition because they live in a state of deprivation. I mean, just on every level, this is absolutely critically important. I really welcome the political emphasis that has been put on this, and it does speak to the fact that I often think that this government does understand the issues and is keen to do the right thing. My question mark is that this, I haven't quite Googled it, but if you put into Google government school foods announcement, you get a good 5 or 10 of similar press releases over the last 10 years. Our government being, a champion at this, you could almost set your watch by it. It hasn't been accompanied by money, although some of the implementation doesn't need a lot. It hasn't been accompanied by mandation, and it hasn't been accompanied by metrics. Without those three things, I'm just worried whether anything is going to happen. And we should get Delia Smith on the page, or Henry Dimbleby, or Jamie Oliver, all of whom have been campaigning on this for 20 years. I don't know. I'm not sure that they would necessarily be body bumping and high-fiving. I think that they might be a little bit skeptical as to whether anything's really going to happen.
Yeah, I mean, Jamie obviously has been out on the news this week talking about it. He had a great line. He said that the school food is the most important restaurant chain in the country.
Yeah,
which I thought was a lovely way of putting it.
Yeah.
But, if you consider what 24% of primary school children are classed as overweight or obese, but the policy, it's explicitly aimed at tackling child obesity, which you and I know a lot about. But the early pilots of this, James, suggest that there was a 15% drop in school meal uptake as children opted out when they moved to these healthier options, which is slightly depressing, for packed lunches, which potentially are often less healthy. So the central prevention paradox here is, do you improve the offer and lose the audience? And that's what worries me. The other point that I would make is we wrote stuff in the child obesity plan actually not about this, and I can't ever recall as Public Health Minister being brought in by the Department of Education for this conversation, which tells a story in itself, doesn't it? But the other point we often talk about wraparound is it's not just what goes on inside the school, it's when you then leave the school, and this is obviously at secondary age, is that do you then walk out the school gate, turn right, and there's a row of shops, in which case there are 3 or 4 fast food outlets. And I would like to see government, and through local government and these new elected mayors that they're going to come online, to be much more muscular in designing the street scene around a healthy living pursuit, because that's surely got to be part of it.
It is. So let me tackle both of those, because I'm so glad you raised them.
Yeah.
So this early bump problem, of course, if you've been serving people fried chicken and chips for 20 years and you've moved to salads and healthy food, of course some people are going to be like, no, I don't want this. I want my chips and jam butty. That doesn't mean we shouldn't do it. And we have this with mobile phones. The first thing that happens when a headmaster brings in a mobile phone ban, a proper locker ban, is that there is objections, often from the parents, and often from a very small number of highly vocal, angry, noisy parents. And then things settle down and people get used to it. And it emerges, as we all know from our own personal habits, that once you've got into the habit of eating healthily, it's a lot nicer, you feel better, you sleep better, you can pay attention. So we've just got to get over the early bump problem. And then secondly, of course, we should close all the KFCs next to schools. It's absolutely horrific.
I agree.
And I am really hard over it. Listen, I'm a red-blooded capitalist. I'm pro the free market, but it is absolutely revolting the way that small independent fried chicken shops and places like KFC absolutely target our children and are contributing to their poor health, and that should stop. But that is not a reason not to do it in schools. In fact, the best gateway to changing children's habits is to use the 8 hours that they have at school to try to give them respite from the absolutely remorseless marketing, both through supply and through advertising, of horrible ultra-processed junk food. Schools can play a really important leadership role. Of course, the primary role of schools is education and getting our kids good exam results. They can't be responsible for absolutely everything. I have a lot of consideration for poor old head teachers who have everything lumped on them. But in this matter of food, it's so basic. And I really do think schools should be given the space to lead on this.
Yeah. Okay. Well, I think it all comes out to money, doesn't it? I mean, we spend about England. We spend about in England. We spend £2.61 per meal. It's lower than anywhere else in the UK and lower than many other parts of the country. So schools will say, "Yeah, we want to do this." And I remember this as a constituency MP. There were all sorts of compromises that had to happen between the school meals provider and the schools. There was lots and lots of unhappiness about this. I think a lot of people in the school system will have heard that announcement on Monday and thought, "Well, how much new money is supporting this from government?" But look, let's see. And you're right. I mean, absolutely, you're right. Google this, and I just did, and there is so much school meals stuff going back. And Jamie Oliver would say it's not lack of rules, it's lack of enforcement and enabling. And so, that's where we are on that. But good luck to government in getting that one. Next story, James.
On Monday of this week, the Academy of Medical Sciences held what they describe as a catalyst event to mark the start of a new policy programme focused on maximising the impact of medical science in prevention and early detection. Steve, it's a great people.
Thumbs up.
You bet. It's led by CEO Ros Campion, who may be known to many who listen to the show as the former head of the Office of Life Science, a really big leader in the life sciences space. And the reason for it was to set out the programme's priorities, share some early insights, and outline how partners across research, policy, practice, and lived experience can get involved. So I'd really encourage anyone who likes the sound of this to get involved. Call Ros. Her number's on the AMS website, and if you don't get a hold of her, send her an email. People speaking, just to give you a sense of how seriously it was taken, included Professor Sir Chris Whitty, Chief Medical Officer and General Good Bloke, and Sir Harpal Kumar, Chief Science Officer and President International of GRAIL, another big leader in the prevention space.
Yeah, that's right. And I know they used the event to unveil their analysis of the UK's prevention innovation landscape, which is obviously something we're interested in. And what's more, James, as you said at the top show, prevention is the new cure. We're there. So huge thanks to the Academy for inviting us to be part of this. We're actually going to hear now from a couple of the speakers who chatted with Charlotte Refsum, Head of Health at Tony Blair Institute and occasional co-host on this podcast with us, who was there for us. She's chatted first to Sir Harpal Kumar and secondly to Emma Greenwood from the Academy. Let's have a listen.
So we are at the Academy of Medical Sciences. We've just heard some really interesting talks. We've heard from Professor Sir Chris Whitty. We've heard from yourself. You are Sir Harpal Kumar. And I was wondering if we could talk a little bit more about some of the things that you touched on in your talk today. I was really interested, first of all, because you had this phrase, you said, science is important, but it's not sufficient. What did you mean by that?
Yeah, so what I mean is that we're actually very blessed in this country in doing fantastic biomedical science, you know, whether we're looking at new treatments or whether we're looking at, as we have done over many years, some of the preventable causes of disease. And what I meant by that comment was that we often develop those scientific insights, but it then takes a long time to move those into practice, whether that practice is clinical practice, something we might do through the NHS, or whether that practice is a more societal one. For example, the sort of progress we make on tobacco. And sometimes it takes us quite a long time to move to implement those insights that we generate from our science. And so what I meant by the comment was we have to think about this both in the context of the additional science we need to do, but also then how do we make that science translate into real impact for the public and the population.
Yeah, that's so interesting, because you also said that you're extremely optimistic. So why do you say that you're optimistic?
Well, I'm optimistic by nature. I'll start with that. But I'm optimistic because I've seen what can be done. I've seen the fantastic progress we've made in infectious diseases, not least most recently through what we were able to do very rapidly during the pandemic. We've made actually pretty substantial progress in cardiovascular disease, but we're still lagging behind many other countries, and so we still have a huge challenge in front of us. I'm optimistic because, quite frankly, we have no choice, right? And why do I say that? If we carry on the way we're going, our health system is going to be unsustainable. And so we're actually going to be forced into doing some of the things that perhaps we haven't been as urgent about in the past. And I think we really have to address this head on.
Yeah, interesting. You touched on a lot of different points in your talk, but you talked specifically about embracing the role of industry and increasing incentives. And I wondered if you could talk a little bit more about that in the role of prevention.
So when I think about how industry in its broadest sense has revolutionized our lives, whether we think about communications technology, whether we think about artificial intelligence, whether we think about electric cars, industry can often bring some of the most innovative solutions to bear that helps us evolve, helps us change our lives in ways that we don't always anticipate. But nevertheless, at least on balance, we move forward as a society. In public health, that hasn't really happened to the same extent. It absolutely has helped in drug treatment. So we have fantastic new innovations in drugs that enable us to treat diseases more effectively. But generally speaking, with the exception of the more recent obesity drugs, industry does not tend to get very involved in public health initiatives. And you have to question why. And industry, again, in its broadest sense, tends to get involved where it can see an opportunity, where it can see a way of bringing those ideas to life that can be a commercial success, not just a health success, if you like. And it's always struck me that we don't embrace that in the public health arena, and that means we are not engaging a very large a section of society, and to be frank, a very big source of funds to actually address some of the problems that we're trying to address. And that's what I mean by trying to figure out what those incentives might be to get industry much more involved.
And are you talking specifically about like pharma companies in that instance, or are you talking about industry that might be involved in delivery of health services, like providers, or some other type of industry? The reason I think about it is because if you think about the GLP-1s, for example, there's about 2.5 million people taking these GLP-1s at the moment. Most of them are getting them off the internet. Now, I've said this before on this podcast, actually, that a lot of the time we know that the clinical governance isn't amazing, and maybe you want something that's halfway house between a GP and getting everything online. But that there's a lot of innovation happening in the private space in terms of models of care that are sort of light touch, low cost, mostly digital. And again, that's happening through industry. It's happening outside of the NHS. And I just wondered, when you're talking about industry and incentives, whether you're just talking about the discovery of the drug, or the test, or the screening, or on the delivery side as well.
All of the above.
Really?
Yeah, definitely.
Okay.
Yeah. I mean, it's this is a massive societal set of issues, and we need to bring all of the innovation to bear. From the development of new technologies, whether that be new screening tests or new diagnostics, all the way through to how do we think about data? Data is a powerful asset out there, and I do very carefully use that word asset because it is something that we have available to us that we are just not using right now. There's an awful lot of information in our data that we are not making great use of. And it could tell us an awful lot about disease, about how we prevent disease, how we detect it earlier. But we're not making best use of that. With the fantastic data companies we have out there, and of course, they can be controversial, understand that, but we have to make use of those insights, those innovations that that industry can bring to bear. And yes, absolutely, then think about how we need to manage those interventions. But we've got to get the ideas, we've got to get the innovations, we've got to get the insights in to addressing what is a very complex series of problems.
Yeah. You talked a bit about data. You talked a bit about the unique kind of place that the UK is in, and having this sort of being a crucible of having, science and genomics and longitudinal patient data and all of those sorts of things. And obviously we've had some developments recently with the HDRS and things like that. What are your hopes for how we can just start to capitalise on some of those unique assets that the UK has?
Well, I think data is one of the areas that gives me a cause for optimism. But again, I'm afraid we've known about this for a long time. We haven't made the progress we should have made. I really hope the advent of the HDRS is going to help us make a step change in this arena. But the fact is we have data in this country that I wouldn't say is completely unparalleled, but it's certainly very rare across the world. And if we could just make use of that information that we have to really understand where those possibilities are, I think we can make really some very, very big step changes.
Brilliant. Well, thank you so much for talking us to this today.
All right, thank you.
So Emma, we are here at the Academy of Medical Sciences. You're new in your role. Tell us what that is.
Yes, so I am newly joined as Director of Policy here at the Academy of Medical Sciences. 6 weeks in, and launching our programme of work in prevention and early detection was top of my things to do list on joining, and one of the things I'm most excited about. You can sort of see in the room today the buzz around it. It's really, hopefully, going to be a really impactful year.
Amazing. You spoke obviously quite a bit about it when you stood up, but can you just tell us a bit more about it here and now?
Yeah, so what we're really trying to do with this policy focus is have a programme of work that is tackling the big, difficult questions. I want to hear a range of views, and for those to be, quite diverse, quite extreme. I want the difficult conversations that, we as the Academy of Medical Sciences can help moderate, convene, and kind of come out the other end with real kind of clarity as to what we need to be doing, both as a nation, but also internationally. Health systems everywhere, I think, are struggling with how to convert the kind of rhetoric and commitment around prevention and early detection into something that actually works in reality in health systems. So what we don't want to do is kind of go away and think about it and then come back and share a final report with everybody. We want to be publishing as we go, be really on the front foot if there's an opportunity to inform government thinking, to make sure that we are really, really mindful of going after the things that can have the most impact at any given time, so that when we get to the end of this programme, we essentially have a whole suite of new original thinking, or indeed that we amplify thinking that's already been done, but really ask the difficult question as to, well, if we have all this brilliant thinking, why hasn't it really translated at pace and scale in the way that we would like?
That's really interesting. And when we were speaking earlier, we were talking a little bit about the value of prevention and how we've sort of underpriced a lot of preventative interventions. Like, maybe you could talk a bit more about that.
Yeah, so I think it's on almost like on so many different levels within the health system. So there's obviously kind of the really obvious value proposition in terms of how do you determine whether an intervention or indeed a pathway of care in the prevention space should be available within the health service, and how does that stack up in terms of how we think about other health interventions. I think there's also then the, once we have something that's proven and we've said, yes, this should be the thing we do, how do we truly value what it can do within a system such that our funding incentives, commissioning structures, leadership within the system at all levels is really ambitiously pushing for that intervention or new pathway to be routinely available to everybody that should benefit from it. And I think there is such an opportunity to think across all of those different layers quite radically and differently, in the way that I think we certainly have the statement of intent to do, but we just haven't quite found a way to operationalise that and to embrace doing some things differently.
Do you know what I was really struck by when we were listening to Chris Whitty, or Professor Sir Chris Whitty, was speaking at the beginning, and he really talked a lot about poverty and actually, some really shocking statistics about health span and lifespan for groups in the lowest 10% of earners, for example. Do you think that poverty will become a part of the theme of what you're doing as part of this work, or is it something you've been thinking about?
So, say that inequalities, the social determinants of health, the poverty landscape, especially in this country, it's just we can't ignore it. We absolutely do not want to focus so relentlessly on kind of the new shiny innovations to the point where we're kind of further creating more of a two-tier system. As Chris Whitty himself said, there's so much that we already know how to do, and we just need to be doing it better, probably tailoring it better to certain parts of the country or certain communities within the country. And I don't think we will be shying away from calling that out. And we want to have a focus on improving where we see those inequalities, and B, we are really conscious of not pushing forward an agenda that would in any way heighten those inequalities. We're just not going to make the progress that we want to see on the outcomes that matter to patients if we don't get that right.
And you referenced your earlier career in cancer. I wondered how much, what's the biggest learning you could take from that work and bring into this job?
Oh, I think the brilliant thing with cancer, or the challenge with cancer, is it's a whole system problem. So the cancer pathway really exposes everything that we could do better in the health system. And I would really love one of the things that we're able to do with this programme of work at the Academy to be real clarity on what the entirety, end-to-end, of our sort of primary, secondary prevention and early detection health system could look like. Because I actually think cancer shows what is possible in that space, from the very classic tobacco tactics in terms of pulling all of the different levers that are at our disposal to, discourage people from smoking in the first place, through to targeted screening programs, through to, if you've had a cancer experience, what is your secondary prevention journey to ensure that you've got the best possible chance of not developing the disease again. And I think I was very lucky to have that experience working across the entirety of what is possible in cancer. And I think there is a real chance now to sort of take the learnings from that and apply that kind of whole pathway, whole system approach to the level of ambition that we have in this space.
So that was great to hear, wasn't it, James? And Charlotte did some great interviews there. So first of all, thank you so much to her for doing that. And it was really interesting. I mean, Harpal first is a very good friend of ours, has been on the podcast talking about the GRAIL trial. I love that. Science is important, but not sufficient. And that from the chief scientific officer. And his point, of course, is that we're not great at turning science into practice for the benefit of the patient and for the benefit of society. And also, I got a real sense of optimism from Harpal. I mean, he sort of makes you look like a gloomy person, doesn't he? He's so, and we know that about him. But he said we have no choice but to be optimistic, because the health system is simply unsustainable if it carries on the trajectory that we're on. So yeah, it was great to hear. What did you think?
Well, he is absolutely an example of the type of person who's spending hundreds of millions of pounds in the prevention technologies, and it's really delivering profound insights. Now, the GRAIL trial, it's been pretty bumpy. It's an absolutely fascinating example of how prevention technologies, you really have to hone them to be pointed at exactly the right problem. It's possible that they weren't quite pointed at quite the right problem in the big trial that they did with the NHS. So that's taken a big bump, but I'm pretty confident that they're going to come back, and there were some powerful insights on how that technology can be used more thoughtfully. But Steve, we're just seeing in so many areas, in cancer vaccines, in diagnostics, in genomics, in hallucinogenics, in dementia drugs, just massive progress being made from a science point of view. The public can smell it. They are getting more interest in trying to head off diseases before they catch them. And we've just got to get those two forces to meet: the appetite amongst the public to and the state of the science. And we've just got to make sure that the infrastructure, the existing legacy of our health system, doesn't somehow get in the way, which one sometimes feels it does.
On that, just at the end of the Harpal interview there, he was talking about the involvement of industry, wasn't he, in public health initiatives, and how we don't do that very well.
No,
but
we don't.
You know, if you then look at the fuss, and it's been right there again this week around Palantir, which we talked about last week, right now, it's hardly encouraging for industry, is it? Because they come in, they invest, and I saw the head of Palantir on, I think it was on Politics Live at lunchtime this week, getting a real kicking. And, you know, that doesn't help. So, you know, that positivity that Harp's talked about needs to come across. The other thing was Emma Greenwood, who I thought was great, actually. It's just clear, isn't it, how central this agenda is to the Academy going forward. And I was struck by her saying, I want to have the difficult conversations. Yeah. And that'll be really good if they do that, because that's what we try and do on this podcast, isn't it? So thank you to them.
What I liked about what she said and the agenda here is, very often when you engage at that senior level with clinically led organizations, they're only interested in prevention in as a tool for keeping people out of hospital or out of a GP, as if prevention was for the convenience of doctors. And if it can't be demonstrated to make a doctor's life easier, then really it's beside the point. That's not right. There are other considerations. There is protecting people from disease, because disease is horrible, protecting the economy, and protecting future generations. So, and also embracing the new science, much of which is in the prevention early treatment stage rather than in the late acute stage. So I love the energy. I agree.
Yeah. And the person you mentioned, Chris Whitty, spoke at that, and he didn't give the interviews afterwards, but we may be able to address that. Watch this space, he said teasingly. But I know Chris said at the event that let's not overlook what we already know in search of shiny new things. He said we already know how to do so much, and I think that's a very key message from Chris, isn't it? Always. So yeah, listen, thanks so much to the Academy for inviting us along and to be part of that event. And thanks to Charlotte for doing those interviews. Just to say, you know, if you want Prevention is the New Cure to be part of your event, we'd be delighted to. And if you email hello@preventionisthenewcure.com, we'll be very, very happy to talk to you about that. Yes.
And can I put a shout out to James Davis? He is our new recruit. He's come on to look after these kinds of partnerships, and he'll make sure that Steve and I turn up on time, scrubbed and prepared, and talk to you about how we can work with you.
Yeah, and I might even wear a tie.
No, that's not going to happen.
No, let's not. Anyway, listen, you're listening to Prevention is the New Cure. It is health and politics every Thursday. Please subscribe. You'll get the episode every week as it drops. We're going to take a quick break, and then we're going to chat with our live guest. Yeah, welcome back. Delighted to welcome to the podcast now Oliver Kemp, who leads Prostate Cancer Research. Prostate cancer remains one of the UK's biggest missed prevention opportunities, with no national screening programme and persistent late diagnosis. So it's a big time for the prostate cancer world, as although the final national screening recommendation has still not been publicly announced, we're expecting it potentially shortly, just after the big local elections on May the 7th. Welcome to the podcast, Oliver.
Thank you very much. Good to be here.
Worries. James.
Oliver, really pleased that you're on the show, and thanks very much indeed for all the hard work you're doing. It's an utterly totemic issue for the show. This prostate screening epitomizes both all of the wonderful aspirations that we have for battling disease and bringing new technology to bear on chronic disease, but also the frustrations of trying to get the system to pivot. Listen, at the end of the day, Oliver, is it possible that the conventional NHS system and the way of mobilizing these expert groups and trying to implement population screening in our primary care system is just not going to work? And we actually are exhausting ourselves and everyone by trying to cram it into a system that was really designed for something else. And we need to be more creative and thoughtful about finding a way outside of the conventional NHS system to do this very important work. To what extent have you been thinking about that?
Yes, well, I suppose we've certainly been thinking about it, because
I bet.
we've found ourselves a bit blooded by the last couple of years, and it's been incredibly hard work, and obviously we've tried all sorts of ways in which to show up-to-date evidence, to be able to show that data can be gathered from other sources. And we're still pushing hard. We're still trying to make sure that the National Screening Committee recommendation is the right one, and they use all the different evidence bases that they could use. And I still think that they're often using old clinical trial data. So, yeah, I mean, we've certainly been working alongside more private enterprise companies, trying to make sure that the diagnostics being pulled through, AI on MRI machines. We've invested in a couple of companies working on that, but making sure that the new biomarkers coming through are being used. We're starting to roll out innovation hubs alongside other providers like Nuffield Health, should be launched in the next few weeks. So there are all sorts of other ways around it, and making sure that we try and reach the people who aren't being reached. There's plenty of PSA testing happening across this country, but it's not always happening in the right areas.
It isn't right. So you just nailed the key point. It's not like the public aren't interested in testing. There's plenty of it going on. It's mainly the Waitrose classes like me who are doing it. And the people in areas of deprivation who don't have day-to-day access to the NHS and aren't in the habit of being engaged, who are often at the most risk, who aren't being reached. So maybe, and the NHS doesn't have a great reach into those people anyway, frankly, and we don't have their email addresses and telephone numbers, and they haven't downloaded the app, and they're not engaged. So there are other groups, either in local authorities or in civic society and community or the charitable sector, or the religious and spiritual communities, who have a much, much better reach and are much more trusted. Why are we wasting our time trying to persuade the NHS to do something it doesn't want to do? And why don't we try to figure out ways of funding a different approach to prevention?
Yeah, and I think the appetite is there. If you talk to any Black community groups across this country, then they're open to it. They realise, 1 in 4 Black men are getting prostate cancer. They want to do something about it. They're seeing families decimated by it. They're very open to working alongside us. And I think even for Prostate Cancer Research, we're a London-based organisation. They do see us a bit of as an ivory tower organisation. We need to be working alongside those groups that have been working in communities for decades. And so that's exactly the type of work that we're really interested in. In fact, we've got a brand new project that just said 81% of Black men still are distrustful of the system. And they refer to Stephen Lawrence, they refer to Damiola Taylor, they talk about Windrush. We've got to make sure that the people who are talking to them are people that they trust.
Yeah. Internationally, Oliver, who's getting it right? If we look across the piece, are there countries, are systems who are showing what a modern prostate screening program looks like?
Yeah, so I think that was across Northern Europe, we've got quite a few really good examples. So Sweden's using Stockholm 3, which is a biomarker test, trying to reduce that over-diagnosis, over-treatment risk. Rather than having a biopsy through your perineum, let's make sure we're trying to pull out the people who really need that test. So they're kind of going through 4 different levels rather than 3 different levels. And every time you do a new level, you're reducing that risk of over-treatment. Taking out prostate that doesn't need taking out is, incredibly harmful. But there are countries, Sweden, Norway, Lithuania, Estonia, who are introducing those new levels and significantly reducing the over-treatment risk.
Yeah, I saw Rishi Sunak, the former Prime Minister, who's obviously spoken a lot about his journey in this space, said that you put prostate cancer squarely on the national agenda. And David Cameron has also spoken. How much has that helped in terms of raising profile? James mentioned the Waitrose classes, of which I am a member. And I actually requested a PSA test recently from my GP. And I'm sorry to say that the response that I got was, well, okay, we can do one if you want. But, we've got all of these celebrities now and politicians who are talking about their prostate health. And, of course, everyone wants one. And, okay, you can have one. And, it turned out to be an okay test. But I was very disappointed in that response. How helpful has it been to have people like David, people like Rishi and the Deputy Prime Minister as well, obviously talking about it?
Well, I think it has to be combined with an evidence base. And I think that's where we've tried incredibly hard. We used Deloitte to do our cost-benefit analysis model. We made sure we were working with an incredibly reputable organisation to show that prostate cancer screening should be brought in for those at highest risk, Black men with family history. And then combined that with Rishi and David amplifying those messages. It's not as though they weren't standing on solid ground. We were making sure that they stood on incredibly solid ground by making. Deloitte had 2 different committees to assess whether the first model was correct before they would even let it really be released. National Screening Committee hasn't done that. Making sure that we were providing evidence that would be taken into account by the powers that be alongside those voices. And there have been some famous celebrities alongside those famous politicians that have also spoken out. Yeah.
Final question to you, James.
How do you see this playing out? What's your prediction? Because I've done a lot of support for this cause in Parliament. I've got stamina, but I'm getting quite worried, particularly after the last Mike Richards report, which was so grim, that I'm talking to a brick wall. Is there a creative way out of this, or have we just got to keep pressing?
Well, we've asked for the model to remain open, and they seem very open to that. So that's a win in our eyes.
Yep.
And if the model remains open, and we can start to feed through clinical trial data that's new and robust, and shows that harm reduction is far more significant than what they've modelled, then I think that's our best opportunity. If they think that 20 people are going to be overtreated for every 2 lives that are saved, then they're never going to do it. But the latest data shows it's two people overtreated for every 2 lives saved. So that changes that makes everything on the spreadsheet on their model go from red to green. So if as long as we can keep that model open and make sure that we hold their feet to the fire and say, put the latest evidence into this model and we'll show you change the numbers.
Well, thanks for coming on the show, Oliver. I think we're right in saying, aren't we, that we're expecting something after the local elections in early May. That's sort of the next big moment in this. And congratulations. I noticed you were recognised in the King's Birthday Honours last year, weren't you, for your work? So well done, you.
Yes. Thank you very much indeed.
Thanks for coming on.
All right, take care.
To get the most out of a gym session, fitness class or a run, do it at the right time of day. That's what health researchers have found out, because your natural internal body clock is very, very important. So early risers or larks like me should exercise in the morning for maximum benefit, whilst night owls should train in the evening. Synchronizing exercise in this way could boost heart gains, especially for people who are already at high risk of heart disease, like me. According to a new study published in the journal Open Heart. What a well-named journal.
Yes.
Volunteers who tried it had better sleep, lower blood pressure, and healthier blood sugar levels overall. So, Steve, could this be the answer to your 30-minute park run dilemma? How is it going?
Well, it's not going. My pre-30-minute park run is my aim. Do you know what, though?
Sub 30, yeah.
Yeah. This was a story that was all over the place, but I saw it right on the top of the BBC News website the other day. Don't feel like exercising, ? Maybe it's the wrong time of day for you. And we'll pop the link to it, as we will to the story in the Open Heart Journal on our socials when this episode goes out. And it just really struck something with me because, I don't love the mornings. That is the truth of the matter. Even as a minister, I used to sort of sit away in my office doing my box first thing because I was far too grumpy. I'm not your guy who's up with the lark. Say, come on, let's be it. I'm a machine. I'm not that guy. I'm probably am better exercising later on, but of course that then causes you need to reorder your life to be able to do that, because then supper time comes in and all the other things that come in the evenings. I need to reorder my life so that my exercise fits into my life, not the other way round. And then I might get more out of my gym session, my fitness class, or even Susan Jebb will be pleased to hear this, my pre-30 park run. Yeah, it was a really interesting story, wasn't it? My goodness, that was a busy episode, James.
Very good indeed.
So much going on. And there was the other big story this week, which just very, very briefly, I'm just going to touch on, but we're not going to discuss in any great detail now, is that the IPPR, Institute for Public Policy Research, brought out a big piece of work this week. Wes Streeting spoke at the launch around whether the NHS is currently set up and funded is really going to work in the long term. This could be a long discussion, but Seb Rees, who heads up health at the IPPR, is going to come on the podcast, and that may well be next week. So if you're interested in that subject, and Seb is a very thoughtful person, we will talk to him in a bit more detail about that report. So I look forward to that, James.
Fantastic. Well, Seb's very good.
Yeah,
Thanks,
he
Steve.
is. Thanks
Really
for
good
listening
to
to the
see you.
podcast. Really hope you enjoyed it. You can find us on all the usual social media channels. You can WhatsApp us 0333 404 6507. And you can email us, as we said, hello@preventionisthenewcure.com. This episode produced by Shortbread Media. See you next week.